I have wonderful patients that I'm grateful that keep coming back to see me. So I wanted to start this off. I'm in my office. So we're going to bring the camera over here. I'm going to show you. It's kind of awkward. Some pictures I have on my wall of my family, kids, nephews, and whatnot. And we're going to swing this around again. Hopefully I can focus in on this picture. This is a picture of my husband and I when we went on a vacation in Thailand. We went to an elephant sanctuary. Part of the experience with the sanctuary was taking care of the elephants. So we fed them, bathed them. We did an exam on them. Part of the exam was busting open their feces to make sure there was the correct water content and whatnot. I know that sounds disgusting, but their feces is pretty much like a big round ball of grass. The other part was we had to do a foot exam on the animal. And unfortunately, the elephant that I examined had pretty terrible feet, and unfortunately, that is common for many people. So we're going to start this off with talking about different nail conditions. So not all nail conditions are fungal nails, but can become fungal nails. There's a lot of hereditary nail conditions. One of them I call a pincer nail, where the nail plate starts to curve in on itself, and it'll continue to curve until it almost becomes like a tunnel. Another common hereditary nail condition is called a ram's horn. It's where the nail has vertical growth and it almost looks like a horn instead of a nail plate. There's medical conditions that can cause nail changes, such as psoriasis. Trauma can cause nail changes, wearing tight shoes, bumping our feet, things falling on our feet. All this can cause the nail to thicken and then eventually change colors, and then unfortunately fungus can set in. As we get older, our nails begin to become a little thin and brittle. Most people don't notice this with their toenails. They do notice it with their fingernails. Unfortunately, it probably had already progressed to the toenails at this point. So what they're noticing now is the fungus in the nails, which the nail becomes thick and discolored. The difference between, fungus in a fingernails versus the toes. In the toes, our shoes provide a perfect environment for fungus to grow. Our shoes are dark, moist, and warm, and that gives the fungus an environment to grow in. Even though fungus is an infection, it's not easily passed from one person to another. Even some people have fungus on one foot and not the other. Once you get fungus in the toenails, though, it's very difficult to treat. Give me just a moment. Probably the best treatment we would have would be oral medication. Most common one is Lamisil. This is a medication where you would take one pill a day for 3 months, and then the medication continues to work as the nail is growing out. This is our best treatment, and it only works about 65% of the time. In order to take this medication, though, it can have an effect on the liver, so patients have to have lab work prior to beginning the medicine and then a month later to see if there was any change in the liver enzymes. If there's no change, they can continue with the treatment for a total of 3 months. If there is a change, then we just have them stop taking the medication and the liver enzymes will return back to normal. I haven't had anybody have any permanent or severe complications when they've taken the oral Lamisil. There are topical treatments, both prescription, over-the-counter, as well as home remedies. The percentage of success is decreased. I tell people that prescription topicals usually work about 30% of the time. Over-the-counters, I really don't have a percentage on it. And as far as home remedies, I have people say that, some things work and some don't. As long as the home remedy is not toxic to the skin, like using Clorox or something like that, I'm okay with a patient trying a home remedy. Often the home remedies really just soften the nail so they have a better appearance, which does make them easier to trim, and so patients do get some satisfaction from that. But really, the true treatment for taking care of fungal nails is debridement. So that's cutting the nail plate back as far as you feel comfortable with, and then using a file to get as much of the thickness away as possible. Next, we'll talk about corns and calluses. I often use these words interchangeably. Hard skin is hard skin. But in general, callus normally will have a hard center that's often on the toes and often is painful, versus a callus, which is usually on the bottom of the foot, usually doesn't have a core in the middle of it and usually not painful and usually found in the ball of the foot. People also come in for dry, cracked skin thinking that this is callus, but unfortunately it's just dry, cracked skin, and all that really can be done for it is some light filing and applying moisturizer constantly, really. Dry, cracked heels, we believe, is because the fat pad is being displaced. So we encourage people not to go barefoot or wear open back shoes. And I've even used heel cups with people to kind of bring the fat pad back under the foot to help with the dryness that can happen because of that. Unfortunately, corns and calluses, a lot like toenails, sometimes the damage is permanent. The only sure way to relieve it is to either have surgery to correct the deformity, and some people do well in orthotics that can offload pressure areas and kind of alter the mechanics of the foot to decrease pressure. The first line of taking care of corn and calluses is taking care of the skin. People can use a file or a pumice stone. They sell lots of devices out there that are to help with hard skin. I discourage people from using over-the-counter callus removers because they do have salicylic acid in them, and acid can cause a chemical burn. Specifically, we tell diabetics not to use these medications, and it even says it on the box that diabetics should consult their physicians before using, and my answer is always no. The second part, or I'm sorry, additional things that we can do for corns and calluses. Corns specifically, they're either due to toes rubbing against one another, or your toe rubbing against the top of a shoe, or if the toe is bent, some people may get a callus at the end of the toe. And there's lots of pads and things out there that people can use to help decrease the pressure so that the calluses don't form as quickly, and it does help with pain. So some of those devices or pads I'm going to show you. Okay, so I have my little foot here. So one of them is using a toe spacer. So I always say this looks like a pork chop, and you put the longer part of the pork chop towards the back of the foot. So what this does is it goes in between the toes, and it keeps the toes separated so that they're not rubbing against one another. You'll still have to do something about the hard skin that's forming. You'll still have to do routine debridement with a file and use lotion. This I call a Silipose Pad. This is something I use quite often in the office. This is a sleeve that goes over top the toe. This sleeve helps protect the toes in a lot of different planes. So this will help, because it's made of rubber, keep the toe from rubbing on the top of the shoe. It'll also keep the toes from rubbing together. If somebody has a callus at the end of the toe because the toe is bent, this is a crescent pad. So the loop part of this goes over top of the toe, and then this pad keeps the toe lifted so the very end of the toe is not bearing any weight. These are very common. You can find these pretty much in any store. So these are just called corn pads, and they have a little circle in the middle, and they're sticky. You stick it where you have a callus or a corn, and the hard part goes in the center, and the purpose of it is to decrease weight. The weight or pressure or friction that's causing the skin changes. Another very important part of people forming corns and calluses is not wearing proper shoes. So people that are wearing high heels, putting a lot of pressure on the toes, shoes that are pointy can cause crowding with the toes, so they're rubbing one another. So we encourage people to avoid high heels and try to find shoes that are wider and also deeper if possible, so that the shoe does not rub on the top of a toe. Some people are put in orthotics. This is more to help with callus that forms on the bottom of the foot, just to redistribute weight and take some of the pressure off where a bone may be sticking down more than it's supposed to. I'm sorry, I keep getting dry mouth. All right, so we're going to talk about some common foot deformities that I see in the office. One is a bunion. A bunion is described as a bump on the side of the foot, and it's whenever the big toe starts to lean towards the second toe. This bump is not extra bone. What has happened is the bone has tilted sideways, and so what we're seeing as a bump is actually the head of the metatarsal bone. A lot of times bunions are considered hereditary. The deformity itself is not hereditary, but the faulty foot type, such as people with flat feet. Bunions can come from people that have a short first metatarsal, obviously something you're born with. People that have hypermobile feet, the first ray, which is where the big toe is, moves more often. We can see bunions form in diabetics as well. Most common symptom of a bunion, although not all bunions are symptomatic, is a bump pain. So for people that have bump pain, we tell them to wear wider shoes. So your shoe must be tight enough that it's pushing on the bump and causing the pain. Some people will actually have pain and inflammation in the joint itself. The bunion you probably have had for many years, but the pain is only most recent. So then we do things to help decrease pressure in the area. Some people may need anti-inflammatories, steroid injections. Sometimes we use orthotics, once again trying to deal with the faulty mechanics. They do sell something called a bunion shield. A bunion shield is just to protect that bump from pressure against your shoe. Even one that wraps around your toe and tries to pull your first toe back into alignment. That first, your big toe is a very important toe. I have patients with a size 5 foot that are 500 pounds, and still that big toe, they could stand on that big toe if they wanted to. It's very strong. So a pad really cannot hold that toe in alignment and keep it there while you're actually walking and functioning with that joint. The only thing that can fix or correct a bunion is bunion surgery. And it's not suggested for everybody. There has to be some degree of pain. I do not do bunion surgery for cosmetic reasons. Next thing we'll talk about is hammer toes. A hammer toe is a toe that's bent or rotated. So most common hammer toes I see are on 4th and 5th toes. Often we're born with toes that rotate like this. The second most common area to get a hammer toe is on the second digit. The reason why a hammer toe forms on the second digit, either that toe is longer than the first and it's overworked and it doesn't want to be overworked, so it bends to kind of get out of the way so that the first toe can do its job. Hammer toes can develop from trauma. People that have bunions often do not have pain in the bunion, but as the bunion progresses, it pushes on the second toe and causes that toe to bend, and usually their pain is in the second toe. But unfortunately, to correct that, we'd have to fix the bunion first and then correct the alignment of the second toe if it's needed. Once again, diabetics do tend to form hammer toes. It's part of the neuropathy, giving bad signals and causing the toes to move around more than usual. Hammer toes in general in the beginning usually are not painful. Usually not painful until people start forming corns and calluses. But as the deformity has been around for a while, that toe starts to become stiff and it won't straighten out. Some of the symptoms people have with hammer toes is they can form corns and calluses, and once again we would use the pads that we discussed earlier to keep the toes from rubbing one another. Some people can actually get pain, inflammation, and redness in the joint. Sometimes it's just changing the types of shoes that they're wearing, although some people may need an anti-inflammatory or even get a steroid injection in the joint to help with the symptoms. The biggest culprit in both of these conditions is the types of shoes that people are wearing. You need to make sure that you have a shoe that fits you correctly. Our feet do change in size and width over the years. Our arches flatten down and our forefoot becomes wider. If you're wearing a size 7, in your teenage years, I can guarantee you're not still wearing that size any longer. So you should have your feet measured if possible. Another common foot deformity I see is flat foot. I'm going to say that there's 3 different kinds of flat foot. First is flexible flat foot. Often we see these in children. When the person is not bearing any weight, it looks as though they have an arch, but when they stand, the arch flattens. Next type of flat foot deformity is rigid. So when the patient's not putting weight down, the foot is flat, and when they put the weight down, it continues to be flat. I like to tease that people's feet are as flat as a pancake. Another type of flat foot deformity I refer to as adult flat foot. This actually is called posterior tibial tendon dysfunction, so you can see why I've shortened it to adult flat foot. Unlike the other 2 types of flat foot, this can occur just on one foot. And the treatments are going to vary between the 3 types of flat foot deformities that I mentioned. So first of all, whether you have a flat foot or not, you could see visually, look at your foot, non-weight bearing and then weight bearing, and see if the arch height change. There's also something called too many toes sign. So if you're looking somebody at the back of their heel, you should only see the baby toe. As people get flat foot, the foot starts to turn outward. This is what we call, once again, too many toes sign. I've seen as many as all 5 toes when looking at them from behind. Another way that we evaluate for flat foot is you can draw a line down the back of the ankle through the center of the heel, and somebody with a flat foot, that line would be at an angle with the ankle tilting inward. Not all flat foot deformities are painful. Most common symptoms is heel pain, arch and ankle pain. Some people that are active, children specifically, can get shin splints. Some people just have a general aching and fatigue in the leg. Some people feel almost like a numbness, tingling, or burning sensation if they stand in one spot for a long period of time. Some people do not have foot or ankle pain with their flat foot deformity, but rather knee, hip, or back pain. So, flat foot deformity does not happen overnight. So if you have pain from flat foot deformity, it's not necessarily the fact that you have a flat foot, but rather the tendons that come from the leg across the ankle into the foot are fatigued. So in this case, we sometimes have to have people decrease their activity. Some people are put in a walking cast and need anti-inflammatories like ibuprofen for a short period of time just to help with the pain. The biggest treatment that I talk about with people with flat foot is being in a shoe that provides good arch support. So I try not to use the word tennis shoes with people. People have varying ideas of what a tennis shoe is. So I usually use the word athletic shoe. So athletic shoe in general is going to provide more support through the arch. Some people are prescribed orthotics for their flat foot deformity. So as far as whenever people are not responding to orthotic shoe modification, medications and things like that, sometimes further investigation is needed. For example, a child that has a flexible flat foot could have surgery. What we do is we put an implant in the joint just below the ankle called the subtalar joint, and that will help realign the foot back under the ankle. People with rigid flat foot sometimes will have something called a coalition, which pretty much called a birth defect, I guess, where two bones, there should be a joint, but those two bones are fused. If they don't respond to conservative treatment, those patients may have to have surgery to have the abnormal bone removed. Adults, once again, often it's just on one extremity. Medicare does not, in general, cover orthotics. So first we work with a shoe modification. Often these patients have to be sent to a facility to get a brace. Opposite of a flat foot is a cavus foot. I'm amazed at how many people have a high arch foot and they don't realize it. They've been looking at the same foot all their life and it looks normal to them. Only people that really know that their foot is a little bit abnormally shaped are usually people that they know that they had a club foot as a child and they had to have reconstructive surgery. Pretty much flat foot is benign. People with high arches, though, sometimes there's a neuromuscular condition that's causing it. And it really is concerning if their foot was a normal arch height and then all of a sudden became a cavus foot. We'd want to send that patient to a neurologist for an evaluation. Common neurological conditions that have high arches, cerebral palsy, Charcot-Marie-Tooth, spinal bifida, muscular dystrophy. A stroke can also cause people to develop a cavus foot. So people that have a high arch foot, often when they're not bearing weight, the arch seems really high, to me anyways, because I know what I'm looking for. But also we see that their toes are contracted. So the toes are kind of buckled up like this. I don't know if that's a good appearance of it. But basically, I can see that they have what we refer to as hammer toes. But when they put weight down, the toes normally will flatten out. Once again, the longer you've had a progression and other things that may have been going on with your medical history, life trauma, and etc., sometimes these hammer toes will not flatten out when people bear weight. Most common problems people with high arches have, they have hammer toe deformities. They can get calluses on the balls of the feet. A high arch person, they're considered to have an unstable foot and often will suffer from ankle sprains. Just like flat foot deformity, we always try our best to do conservative care, which would be orthotics and possible shoe modifications. One of the most common foot problems I see in the office is something called plantar fasciitis. They also call this heel spur syndrome. Sounds like a fancy name, but basically we just put itis on the ends of things to say that there's inflammation. And this band of tissue is called the plantar fascia. Once again, itis, now it sounds like an important medical term. People that have plantar fasciitis can have a heel spur, but they don't necessarily have to have one. And there's people that have heel spurs that probably will never develop any heel pain. We concentrate on treating the tendon and not worry about so much the heel spur. The heel spur, though, develops because the tendon is tight and then it's attached to the heel bone. And when we use this tight tendon, it pulls on the bone. The bone thinks that it's being injured and produces more bone in response. And then voila, you have the heel spur. Often heel pain, we don't really have a cause for it. It's very common in people with low arches and high arches. Usually there is not an injury. Sometimes it's just a small change in activity. Somebody started a new job, maybe at the same job, but they're working more hours or their activities at the job change. Some people remember a specific shoe that may have irritated it. I see heel pain in the fall when people have been going barefoot, wearing flip-flops and stuff in the summer, and that band of tissue on the bottom of the foot got irritated. The most common symptom for plantar fasciitis is heel pain, although some people do have arch pain. The pain is either on the inside of the heel or in the center of the heel, and most people will complain that the pain is worse after rest. So that means pain would be worse when you first get out of bed in the morning. After you walk around a little bit, that plantar fascia stretches out and the pain does improve. Sometimes the more you're on your foot, the pain will continue to progress. All you want to do is get off of your foot. So you sit down, you feel a little bit better, and then when you go to stand up again, the pain can actually be worse than before you sat down. Plantar fasciitis is very successfully treated with conservative care. And this conservative care consists of first wearing shoes that have good arch support. That plantar fascia is part of the arch, so the shoes can provide some support. We have people do calf stretches. This is a tendonitis, so we want to stretch the tendon out in a controlled way. Some people are on anti-inflammatories for a short amount of time. Most people are going to get well with avoiding going barefoot, wearing good shoes, doing some stretching, and possibly some medication. Other people will require night splints, orthotics. Some people will go on to physical therapy. And some people will require an injection to get rid of the plantar fasciitis. Most people do not need surgery for this condition, and we prefer not doing the surgery if possible because it's not a corrective surgery. Literally, what I do is I make a little incision on the side of the heel and I stick a pair of scissors in there. Versus corrective surgery, like if you had a hammer toe surgery, your toe is bent. At the end of the surgery, your toe is now straight. It is successful, when it's needed. But like I said, in most cases, it's going to heal without any surgical intervention. Next thing I'll talk about is arthritis, most commonplace. Hold on just a second. All right. The most common place to get arthritis in the foot is the big toe. We have a special name for it. It's called Hallux Rigidus. Hallux just means big toe, and rigidus means that there is limited motion in the toe. Most likely, arthritis in the big toe is due to trauma, wear and tear. Once again, people with flat feet and high arches will often get this. In a joint, there is a cushioned area called cartilage. Whenever there's pressure, abnormal pressure and motion at the joint, that cartilage starts to wear away. And then at some point, the two ends of the bones of the joint will grind one another, and then people get like a bony prominence on top of the foot. There's other types of arthritis that can happen with the big toe. Probably very common would be gout. Gout often we don't see on x-ray. It's a clinical diagnosis, and people come in with a swollen, red, inflamed toe, and can either be treated with medication or possible steroid injection. Other conservative care for people that have arthritis in the big toe is wearing a stiff sole shoe. The point of this is the less the joint moves, the less painful the joint would be. Some people need orthotics. The orthotics are to control motion, but also we put something on it called a Morton's extension, which decreases the motion at the great toe. Once again, less motion, less pain. The last thing I want to talk about is diabetes. It's suggested that diabetics have a yearly foot exam. This is for preventative reasons. There's 4 areas that I'm looking at when I do a diabetic foot exam. First is checking the circulation, checking for your pulses, make sure you're getting good blood flow coming down, and also checking for swelling and varicose veins. If I couldn't feel your pulses, most likely I'd order some tests, and then possibly a referral to a vascular doctor. People that, you've heard lots of stories of a diabetic that cut their toenail, and then all of a sudden they lost the toe and then part of the foot and the leg. And what, yeah, it's because they cut their toenail and caused some bleeding, got an infection, possibly, but this almost always is due to poor circulation. So if they were coming in for foot exams, they would have known that their circulation was poor. They would have had the test and been referred to a vascular doctor for treatment before the injury occurred, and you definitely can save toes because of this. I have a lot of people that come in for swelling in their legs and feet. Sometimes this is just a natural progression of life. For the most part, swelling in the legs are treated with elevation, compression stockings, and we do ask people to walk around for at least 20 minutes a day. The muscles from walking will help squeeze the blood vessels and get the swelling out. The next part of the exam for a diabetic is checking their skin. I'm looking for corns and calluses, pressure areas, dry cracked skin, infections. Diabetics tend to have drier skin, so dry skin can lead to cracked skin. Cracked skin can open and lead to infection. We do ask diabetics to put lotion, moisturizer on their feet regularly to avoid some of these problems. And then, of course, we treat the corns and calluses in the office and make any suggestions that they may need. The second part is checking their sensation. Diabetics often can get a condition called peripheral neuropathy, in which there's nerve damage from the diabetes. It normally starts in the toes, can progress into the foot, up the leg, and some people have neuropathy in their hands as well. Neuropathy, for the most part, once it occurs, is permanent. There are medications to help with pain. We ask diabetics, specifically ones with neuropathy, to check their feet daily. You can no longer count on whether something's painful or not as a gauge on whether it needs to be treated. Anything that looks abnormal should be evaluated, and we tell diabetics not to walk barefoot because you want to avoid stepping on anything or hitting the foot against a table leg or something like that. The shoe will protect you from that. And then the last thing is I'm looking for foot deformities, bunions, hammer toes. And then what we would do is initiate the conservative treatment, which would be, looking at the types of shoes they're wearing, possibly using pads and things to offload pressure areas. Diabetics do qualify for diabetic shoes as well. All right, that's all I have for you today. If anybody is online and wants to ask any questions, I can answer some questions now.
Well, while we wait for questions to come in, if anybody is with warmer weather, if anybody is walking more or starting an exercise program with the warmer weather, what are some things we need to watch for as far as pain? Should we worry if it just hurts all of a sudden, or what are some things we should look for?
Okay, so it's great for us all to get out there and walk, exercise. I told you helps with swelling and things like that. Probably the most couple of important things that you can do for yourself is, first, you should stretch before you go out for that walk. And what you're going to be doing is stretching the back of the leg, what we call the calf muscle or the Achilles tendon. We need a proper heel to toe gait to avoid injuries and things like that. And stretching out that tendon will help you warm up for the exercise, but also loosen up the ankle and give you more range of motion to get that normal heel to toe. Also, it's the type of shoes that you're wearing. Once again, swelling. All of our feet swell a little bit, and unless you're in your teens, you want to make sure that you're wearing a shoe that gives you a little bit of extra room, one that has a thicker sole and arch support. And you want to be careful on what surfaces you're walking on. Be mindful of cracks in the sidewalk and whatnot.
Okay, there's not any other questions right now, but if anybody wants to submit any on Facebook or via Teams, we can certainly follow up with you. But other than that,
okay. All right. If there's any of my patients out there watching this, once again, thank you for coming to see me.